Today we are at Day 2 CSICON 2019, which is being held at the Ashok Hotel, New Delhi. I am Dr. Rahul Kotwal from medical team of McLeod's Pharmaceuticals. Today we have Dr. M.S. Hiremath sir with us, who is Director of Cath Lab, Ruby Hall, Pune. He was also a past president of CSI and earlier chairperson of NIC. Sir has delivered a session on DAPT, dual antiplatelet therapy, when, how long and which one. So sir, what do you think? The newer generation of antiplatelets are better, or the clopidogrel, which is an older one?
Hello everyone. Clearly we now know that the newer ones, the prasugrel and ticagrelor, are better compared to clopidogrel, definitely under acute setting. So for ST elevation and non-STEMI, these two are more important compared to clopidogrel. In fact, ticagrelor scores over prasugrel because it can be used for those who go for angioplasty, those who are maintained on medical therapy, and those who go for CABG because of its dilatory action on the microcirculation. So overall, this is one molecule which fits into all categories of ACS management. Okay. So I would generally prefer using the newer molecules compared to the earlier clopidogrel, though I must confess that for a decade and over, clopidogrel ruled as an antiplatelet therapy.
Right, sir. Well, sir, there is this thing, stent thrombosis. So what is the role of newer generation versus older generation of DAPT or antiplatelet agents in stent thrombosis?
Yeah, stent thrombosis is something which the interventionists worry tremendously. Stent thrombosis in key location like LAD proximal or left main bifurcation is extremely dangerous, and patient could be brought to emergency room almost gasping or in severe cardiogenic shock. So this is something where I think the two newer molecules have sort of helped us tremendously, increasing our reach to the more complex areas, especially the left main. If you see the guideline directions, left main is now moving towards angioplasty compared to previously for CABG indication. So there is something like non-responders to clopidogrel, and these is a sizable percentage. Add to it the resistance to aspirin, and you have a sizable patients who are non-responders. If this happens in the early weeks after stent placement, when the stent is really not covered by the endothelial lining, the patient comes with stent thrombosis. Fortunately, the two newer molecules have what we know as no non-responders, and that's why once you do a good job, we are almost certain these days that patient will not come with stent thrombosis. Add to this the imaging techniques which we use towards the beginning as well as end of the procedures, which help us make the procedures perfect, and this would again reduce the incidence of stent thrombosis. So what was considered a reasonable percentage in 2006, 10 years down the line, we feel that these two newer molecules have helped us to bring it down close to maybe not zero, but less than 1%.
Right. So sir, because of less experience, there is an
antiplatelet agent is the ischemia benefit. Downside is going to be the bleeding risk. So in early days we used to think that keep it short and maybe afterwards continue only with aspirin. There was a change towards 2006 when some of these studies indicated that longer the duration, bigger the benefit, and this happens because beyond 1 year we are not really worried about stent thrombosis, but the acute events comes from the non-culprit lesions, like you stent an LAD today, and now after 4 years the infarct comes from the RCA. So we have clearly an issue that it's a progressive happening coming from the non-culprit sites, and that's why the antiplatelet cover could be stretched. We all agree that if you give it for a longer duration, the ischemic benefit is clearly there.
Right.
But as I mentioned, they could bleed, and that's why you have to strike a balance. So in 2019, if you discuss, most of the time we are talking of individualizing the dose of antiplatelets. So on one side, you calculate the possibility of bleeding. So given a patient who is, say, a female patient, low weight, something like 45 kilos, and elderly, something like 75 years and above, I would feel the bleeding risk is going to be very high. We have some scores like precise DAPT or DAPT score, which tell us that this is a high bleeding risk patient, what is called as HBR. So if you have an HBR, you are expected to keep the duration short. If you have a low risk of bleeding, keep the duration long. And this is where two important studies, the DAPT study and the Pegasus study, actually both exclude bleeding inside first 1 year. So it is beyond 1 year that these two studies really help us guide. So those who have not bled in first 1 year, and if it is a low bleeding risk, try and continue the DAPT for a longer duration, and you will probably gain the ischemic goals. But if you give additional aspirin, the bleeding risk really goes up. So when you want to consider long, these days we have an option of giving only a SAPT, that is a single antiplatelet therapy, and not add aspirin. And this would prevent bleeding risk, and thus the ischemia benefit can be maintained or could be made stronger.
Okay. So, what is your opinion on switching of antiplatelet agents like
Yes.
ticagrelor or prasugrel and clopidogrel?
Firstly, switching is an art, and it's quite tricky too. So always take your intervention cardiologist in your confidence, discuss with him before you make a switch. It's not easy. Switching in first 3 months extremely risky, so don't ever attempt unless something is very dangerous that is going to happen by continuation. So switching inside 3 months, don't do it. Switching is okay later, say after 1 year. So we have two kind of switches which are important, and it's an early switch, that is within first 3 months or so after an angioplasty, and switch which is late, which is like 1 year and more. In all these switches, mostly we are trying to de-escalate. That means we are trying to move away from the stronger molecules like prasugrel or ticagrelor to a softer molecule like clopidogrel, because in longer duration maybe we are trying to reduce the risk. However, two important studies, the Pegasus, which use a smaller dose of ticagrelor, longer duration beyond 1 year, that was 60 milligram twice a day, and certain other studies have shown that single molecule used without aspirin, long duration can be pretty safe. So here, when you are trying to switch in the early phase, like around 3 months, for whatever reason, like some of the ticagrelor patients may have dyspnea as their side effect, some may have sinus pauses, and if you decide to switch them to clopidogrel, always reload. So last dose of ticagrelor, next morning you give loading dose of clopidogrel, and then maintenance dose of clopidogrel. So switching from ticagrelor to clopidogrel or prasugrel in the early phase, you must reload, and vice versa too, like patient on clopidogrel. This is standard scene because most of the LICE patients are on clopidogrel. So when they come to Cath lab, we always reload them with ticagrelor and continue with the angioplasty and continue ticagrelor subsequent to angioplasty. If you are loading later, like say after 1 year, and you are trying to switch between clopidogrel and prasugrel, I think you can give a short overlap and not really reload, because the duration of prasugrel as well as clopidogrel is longer compared to ticagrelor. So if you have any surgical procedures, the stoppage is just about 3 days recommendation for ticagrelor compared to 5 days for clopidogrel and 7 days for prasugrel. So switching an art also depends on whether the patient had just one stent or multiple stents, and based on other factors too, patient factors as we call them. Somebody who has CKD, somebody who has diabetes, they're more prone to stent thrombosis. So maybe you should use them for a longer duration.
This is a beautiful thread, sir, that you have given to the audience. Apart from this, there are certain kind of patients who need both antiplatelet therapy and also oral anticoagulants, maybe DOACs or NOACs. So what is your opinion on that?
I think we have two clear studies where you want to combine OACs, that is the oral anticoagulation, with the antiplatelet agents. Most of the time this situation arises when patient is already in atrial fibrillation and you have to do an angioplasty for ACS, and also patient has an ACS today, you do a stenting, and within a short time, like say a month or so, patient becomes atrial fibrillation case chronically, and you are forced to give anticoagulation too. So the two studies, the Reduel PCI and Pioneer AF, they clearly indicate that the dabigatran and rivaroxaban respectively can be quite safe along with anticoagulation. Along with antiplatelet agents, clearly safer than warfarin. Many people feel that warfarin, we can adjust the dose and adjust the INR accordingly and probably feel safe. But these are two studies which have strongly indicated that NOACs are probably safer with DAPTs under these kind of combination settings. Also, people think that clopidogrel would bleed less compared to the newer molecules when you're using with the NOACs. However, the data also indicates that you can combine the NOACs with either prasugrel or ticagrelor. Always important to remember that when you are combining these three, like two DAPTs and the anticoagulation, it could be warfarin, it could be NOACs, whatever. If your patient is average bleeding risk patient, first 1 month you give all three. Depending on how you rate the bleeding possibility, you continue them for about 6 months if it is a ACS case and low risk. And at the end of 1 year, the patient goes only on anticoagulation and no antiplatelet agent. So between 6 months to 1 year for an ACS case, patient will be on one antiplatelet and oral anticoagulation. In stable cases, the shorter the overlap, it's allowed. So maybe we keep, especially high bleeding risk cases, we keep the overlap for just 1 month and switch to one antiplatelet and one anticoagulation up to 6 months, and subsequently a patient can be only on oral anticoagulation. But definitely beyond 1 year, patient gets treatment more for atrial fibrillation and less for stent-related issue, right, and he would be only on NOACs.
Right. So, sir, many of them feel difficulty in individualizing the therapy or individualizing the treatment. Sir, if you can guide us on that.
Yes, as I told you, who are the high risk for bleeding, and I mentioned earlier female patients, low weight, elderly, these are very high risk for bleeding.
Right.
And they should be clearly treated with special gloves compared to a conventional case. These days, apart from age, frailty is becoming a very important factor, and this again needs to be considered. Which one will you choose? That's the question, whether you would accept a bleeding possibility or an ischemic benefit. And so when this question comes in a very delicate case, as I mentioned, high risk for bleeding and also has a complex angioplasty. So in these settings, bleeding can be very risky. So I think I would rather play it safe and probably use DAPT, probably use it for shorter duration DAPT, and then switch to a single antiplatelet agents.
Yes.
But not aspirin. For me, single antiplatelet is not aspirin. For me, one of the three is very important.
Right. So, sir, I really thank you very much for guiding us on this topic. It was really very helpful and beneficial for the audience out there. And we also thank you for being part of this channel and this session summary. I know that because of time constraints, there may be any doubts of audience, which we definitely look forward to have in the comment section below. And we thank you for your presence, sir. Thank you very much.